you want me to start? Can I start? Good evening, ladies and gentlemen, and welcome to this part 3 of the series of webinars on the Cardiometabolic Academy. My name is Wael Al-Mahmid. I'll be on my own today. Dr. Fathiya couldn't make it. This Cardiometabolic Academy is brought to you by the Emirates Cardiac Society and the Emirates Diabetes and Endocrine Society. A few housekeeping before we start. The webinar is being currently live streamed on YouTube. It'll also be available on demand on the Emirates Diabetic Society website. Please type in your questions in the Q&A. And also live chat support is available on the WhatsApp, and you will be able to get 2 hours of CME from MOHAP. Our first speaker today is Dr. Alauddin Bashir. He's a consultant endocrinologist from Dubai Hospital and current president of the Sudanese Diabetes Association Gulf chapter. He is very active in the society and in Dubai and in the Emirates, and he has more than 70 papers and review articles. He will start by talking to us about the diabetic mellitus guidelines regionally and internationally. Welcome, Dr. Ala.
Assalamu alaikum. Thank you very much, Dr. Wael, for this nice introduction. When I was actually asked to present this topic about a deep dive into diabetes guidelines, I thought all the webinars around are talking about the recent diabetes guidelines, and they all talk about the high-risk population and patients with cardiovascular and renal disease. And I thought, what could I add to that? And I thought, let me take something very practical that we see every day in our clinic. And I thought to look at the complexity of patients who come to our clinics and to see how can we handle these complexities. So what I would like to do is to go through this presentation. I'm supposed to have 25 minutes. Probably I'm going to finish earlier than that. I'm going to discuss the complexity of diabetes management for patients and physicians. And I'm going to talk about the prevalence of cardiorenal disease in patients with diabetes. And I'm going to pick specific messages from the guidelines, and I will end up my presentation with a conclusion. So I'd like to start it with this patient, Mr. M, who is 56 years old, and he's a banker. He's diabetic, hypertensive for 12 years. He's obese, he has fatty liver, and he's a smoker. He's struggling with a peripheral diabetic neuropathy, and his blood pressure when he came was around 152/90, and his BMI is 38. So when we looked at his A1C was 9.8, and his LDL was around 112. Albumin creatinine ratio is 65, creatinine 1.1, and eGFR is 58. And these are the medications he's taking. He's on a full list of medications that include anti-diabetic, antihypertensive, aspirin, lipid-lowering agents, medications for alpha-lipoic acid for his peripheral neuropathy, and some vitamins as well. And when he finished his consult with us, we gave him a couple of advices. We asked him to go and do exercise daily, to try to quit smoking, and we gave him a referral for to quit smoking, to get the help for that. And we asked him to watch his diet, to minimize his calories, to take a low-fat diet, to look a low-carb diet, to meet a dietitian, to go and meet a diabetes educator, to go for a foot care regularly. And we asked him to check his feet every day regularly, to do a self-monitoring of blood glucose like 2 to 3 times daily, and on top of all of that, he was taking 10 tablets per day, and we added for him an extra tablets as well. And this is exactly Mr. Ahmed when he left the clinic. He was completely confused, thinking about all the advices we gave him, the medications that we asked him to take, the food and the diet that he has to follow, how to take care of his diet. So he was completely confused. And now, if you look at this regular patient who comes to our clinic and you think about it, this many advices, this many medications, what do you think will happen next visit? Do you think he's going to come with a normal A1C next time? I think we're adding, with these much advices and the complexity of treatment we give, we're adding more to the confusion of this patient. And that will probably add to their burden of diabetes. This is a study that looked at around 5,255 patients with diabetes. And the study basically looked at the hours spent per week in diabetes-related tasks. And you can see around 44% of patients do spend 1 to 5 hours on just doing some diabetes-related tasks. And you can see there are different groups of people who spend either more or less. So diabetes takes a good part of our patient's life, and it's our duty to make it easy for them. So, and with this complexity, with this complexity of treatment, I think our patients might be even less motivated, and then we need to go into a less stringent targets for them. So we should find a way to handle that. But this is only one side of the coin. If we look at the other side of the coin, where the physician is allowed to have 30 minutes to talk to a patient and to handle all these issues at the same time. Talk to the patient, give him advice, write your medications, handle his diabetes, hypertension, lipids, cardiovascular risk, stress, polytreatment, peripheral neuropathy, and then don't forget the screening of the feet, don't forget the regular microalbuminuria check. So this is a huge burden that a physician as well has to finish within 30 minutes, if not less. Most of the time, we do spend even sometimes less than that, and we spend more time later on documenting the patient on patient's medical records. So, and what adds to the burden on the physician as well is that they usually try to even calculate the patient cardiovascular risk in order to decide whether to start them on treatment or not. And I looked at different risk calculations or risk stratification in different organizations. And the truth is, I found the one developed by the Emirates Diabetes Society is more easy. You don't need to go into an online calculator to check the 10 years risk. It's very simple. You ask yourself 4 questions and you get the risk for the patient. So the first one and the most important question is you ask your patient or yourself whether your patient had a previous cardiovascular disease or not. If yes, then he's very high risk and you're done. But if the patient is not having a previous or an established cardiovascular disease, then you ask yourself another 3 questions. The first one is your patient more than 50 years or less? And the second, how long is the duration of diabetes? And the third is how many risk factors you have. And based on that, you decide whether your patient had moderate, low, or high, or very high risk. So if a patient already had an established cardiovascular disease, that's a straightforward, very high risk. Then you ask yourself the question of the age. If the patient, is the patient more than 50 or less than 50? And if your patient, and the next question is, how many years do they have the diabetes? So if I had a patient who is more than 50 years and he had a diabetes more than 10 years, then this patient is very high risk. Straightforward, you don't need to ask yourself any other question. And if the patient is more than 50, more than 10 years, and he had no or only one risk factor, then that's a patient who is high risk, not very high risk. And if he is more than 50 and diabetes less than 10 years, but he has risk factors, then again, he's high risk. If your patient is less than 50, has a diabetes for more than 10 years, and he has more than 2 risk factors, he is also high risk. So what you could conclude here, a patient who is less than 50 is probably low to moderate risk, unless he has diabetes for more than 10 years and he has more risk factors. And then comes the moderate and the low risk, which usually is a smaller number than the people we usually see in our clinic. So if we look at United Arab Emirates, for example, and we look at the data from United Arab Emirates, around 30% of death in United Arab Emirates are related to cardiovascular disease. And another probably 20% are related to non-communicable diseases and diabetes, which at the end up with a cardiovascular disease. So overall, I would probably say we have around 50% mortality in United Arab Emirates related to cardiovascular disease. And when we ask ourselves, is this just an atherosclerosis, or we have other variants, let's say, of cardiovascular disease, we look into the data, and this is a study, the Veterans Diabetes Study, that has found that if you look at patients with diabetes and you divide them into quartiles based on their A1C, then you would see an increased risk of heart failure with the increase in hemoglobin A1C. So people with an A1C more than 9 has a higher risk than patients who had an A1C of 6.4. And if we look at data from the UK Caliber program, it says that heart failure is the second most common cardiovascular disease following stable angina. With heart failure, there were around 12,087 events per year in that program, and that is more even than peripheral vascular disease. So, how can we handle cardiovascular disease and heart failure earlier in diabetic patients and patients with pre-diabetes? And how can we address that? I think the answer, probably you all know, is an extremely simple answer. If we look at all the recent cardiovascular outcome trials, it tells you that we have medications that handles both atherosclerotic cardiovascular disease as well as heart failure. And one of these studies is the EMPEREG trial. This is just a summary of the EMPEREG trial. The benefits that you get by starting empagliflozin, if you treated 1,000 patients with type 2 diabetes, you would save around 25 lives, and you would save around 22 cardiovascular deaths, and you are going to prevent 14 hospitalizations for heart failure. And that with a price of 53 additional genital infections and 7 additional genital infections leading to discontinuation of treatment. So total benefit definitely exceeds the risk with the use of SGLT2 inhibitors. The second class is the GLP-1, where if you look at the LEADER trial, liraglutide has significantly reduced the primary cardiovascular endpoint by 13%, which is the 3-point MACE. But even if we look at the components of the primary endpoint, they were all reduced significantly. There is a reduction in cardiovascular death by around 22%, and there is all-cause death has been reduced by as well 15%, microvascular events as well as renal events. And if you look at the p-value is significant in all of them. And this is not the only GLP-1 that has shown similar benefits. It's just for the sake of time, we have seen similar results in SUSTAIN 6 trial, where we could see benefits from semaglutide, and we have seen even from the oral semaglutide in the Pioneer 6 program, where there is the primary endpoint was neutral. However, there was significant improvement in cardiovascular death with the use of oral semaglutide. So even if we go to the same class and we try to look into even non-diabetic patients, we would see that even non-diabetic patients with heart failure do benefit. And that was the results from the DAPA heart failure program. There were around 55% of patients who didn't have diabetes, and around 45% of patients had diabetes. And there was a benefit across the board, whether patients are diabetic or not diabetic. So if we look at all SGLT2 inhibitors, whether the design of the study was primary prevention or secondary prevention, there was significant improvement in heart failure, hospitalization for heart failure and cardiovascular death, renal composite outcomes, as well as cardiovascular death in the MPEREG program. So what does the guideline advise then? After we know that we have the tools that can help us to help our patients and go for, let's say, a more or less complex treatment. So if we look at the evolution of the guidelines since 2016 until now 2020, until 2016, the guidelines focused basically on glucose lowering, while 2017 onwards, after the results of the MPEREG and the LEADER program, they started putting the SGLT2 inhibitors and GLP-1 as second-line therapy. But the evidence was not very strong. It was level B evidence initially. But in 2018 onwards, adding an SGLT2 or a GLP-1 started to have level A evidence. And this is the slide that I told you that you've seen a lot of times, and I'm not going to talk about it at all. I'm going to take you into a small messages or small pieces of the guidelines that convey the right message to treat our patients early and to reduce the burden of disease on them without causing more confusion. So the first message from the guidelines, it says that we need to start cardiorenal protective agents early, regardless of hemoglobin A1C. And if you look at this, this is the first part of the guideline. It says that metformin is the first treatment, and that should be with a comprehensive lifestyle change. And if your patient had an indicator of high risk or an established cardiovascular disease, you need to consider SGLT2 and GLP-1 early and independently of hemoglobin A1C. So we have a patient, we look if the patient has high risk. For example, our patient M has diabetes, hypertension, dyslipidemia, obese, smoker. So he has multiple risk factors. So this is a very high risk patient. So from the start, I will go and I will look at the patient, whether he had more of, is it an atherosclerotic cardiovascular disease or indicators of high risk? If there is, then I could either use a GLP-1 or an SGLT2. Is my patient having a higher risk for heart failure? Then probably I will go more towards SGLT2 inhibitor rather than a GLP-1. And when it comes to chronic kidney disease, which is part of the equation in management of patients with cardiorenal disease. So we look, if the patient had a diabetic kidney disease and albuminuria, then SGLT2 are more preferable than GLP-1. But if it is a non-diabetic kidney disease and no albuminuria, then GLP-1 with proven cardiovascular benefits, or an SGLT2 would be used in such patients. So, and that was not actually the first guideline to say, this is 2021. Now in 2019, it has been even mentioned, and it has been mentioned that GLP-1 and SGLT2 inhibitors should be used to reduce the major adverse cardiovascular events, hospitalization for heart failure, cardiovascular death, or CKD progression. And that should be considered independently of baseline A1C. The second message from the guideline is to avoid the inertia. And what does the guideline say? If you have a patient who has been started on metformin and he is not achieving his target, then to avoid clinical inertia, reassess the patient and modify treatment regularly. That means every 3 to 6 months, the patient treatment has to be readdressed, modified, and changed regularly until you reach an adequate hemoglobin A1C. Actually, there are even other guidelines, and this is the European Society of Cardiology, who took a more bold step where they said, you might need to start even these cardiorenal protective agents, even if the patient is not on metformin. So if a patient comes to you with an atherosclerotic cardiovascular disease and he's metformin naive, start it. And then probably you would be able to add metformin after that. The issue here is that there are some gaps in the management of patients with diabetes and cardiovascular disease. And I'll tell you that through this study. This is called the Capsular Study. It's a first global study that looked at patients, the prevalence of cardiovascular disease in patients with type 2 diabetes. It's a global study that has included so many countries across the world, including our area where they included patients from Saudi Arabia. What is interesting in this study is that 1 out of 3 people with diabetes has cardiovascular disease. So 30% of patients with diabetes has cardiovascular disease. What is again interesting is only 2 out of 10 people with type 2 diabetes are getting the right medications. And I'll show you this in this graph. If you look here, that we said 1 out of 3 patients has diabetes. And if you look, 38% of patients in this group had even chronic kidney disease, and 26% of them, of patients with chronic kidney disease, were actually hypertensive. And if you look at their medications, this is the cardioprotective medications here on the right side of the screen, where you can see the SGLT2 inhibitors and the GLP-1. Look at the patients with cardiovascular disease. How much is the percent of people who has been started actually on SGLT2 inhibitor? It's almost 16%. So 100 patients, only 16 would receive the right medicine, SGLT2 and GLP-1. Probably one of you would ask, well, maybe the cost is an issue. If you look at even our area here, Saudi Arabia is a wealthy country, alhamdulillah. And then even in Saudi Arabia, the number of patients who has been on SGLT2 inhibitors and GLP-1 is very small. Our patients are not getting the right treatment. So the third message from the guidelines is to start early combination therapy. So don't wait. You can, from scratch, start your patient either on metformin plus a GLP-1 or metformin plus an SGLT2. And this is actually very more than a single guideline. This is the ADA 2021, where they said early combination therapy can be considered in some patients to extend the time of treatment, to avoid the treatment initiation and to extend the time to treatment failure, and especially if the A1C is more than 1.5%, the target for that patient. There is another guideline, which is called the Primary Care Diabetes of Europe. In their guidelines in 2020, they said that in patients with CKD, CVD, they should consider initiation of metformin and SGLT2 inhibitors together from scratch, rather than in a stepwise approach. And that metformin should be first line, usually, as long as the eGFR is above 30. But below 30, you can start the GLP-1 straight. And the benefits of combination therapy is actually well known in treatment of hypertension and in treatment of diabetes. I'm just going to quote this one study. It's a Japanese diabetes population study that included around 12,300 patients. And they looked at the probability of patients remaining on treatment, that's the persistence on treatment, over a 1-year period. And if you look at the blue line, those are the patients who continued to be on treatment. Sorry, the orange line, the patients who continued on treatment, and those were basically the patients who had a fixed dose combination. And the difference was around 27%, and that was statistically significant. So start early therapy early, up-titrate your treatment as soon as possible, use fixed dose combination because it helps your patients and it reduces the burden on the number of tablets they take every day. And if we go back to our patients and we implement this approach, I guess this is a very satisfying approach for all our patients, especially if you look at this circle, the blue circle of the Diabetes Day, the World Diabetes Day. If you look behind this circle, basically you can see a huge number of medications that can be used in combination, whether dual B-bars, TZDs, metformin, inhaled insulin, whatever, we can use them in combination to avoid or to maintain our patients on treatment and to improve their compliance to treatment and persistence on treatment. And I think one of the best approaches for such patients as well to reduce their burden is to reduce the number of their visits to the clinic as well. So if we do have a patient who visits the endocrine clinic separately and a cardiology clinic separately, it would be advisable to have a cardiometabolic clinic where those patients come to the same clinic where they meet their cardiologist and endocrinologist who would agree with the best management to treat their diabetes and cardiovascular disease. And with that, I will probably finish my presentation and I will leave you with the conclusions that diabetes prevalence is growing and that second-line treatment for diabetes should be based on heart and kidney assessment, and that SGLT2 and GLP-1 are preferred second-line in a large group of people with type 2 diabetes. However, it is extremely underutilized, and we have to raise the awareness of our physicians and population on the use of these medications. And we need to check our patients' compliance regularly. We have to check their medications, their A1C every 3 to 6 months, and up-titrate our treatment as early as possible. Thank you very much for your attention. And the mic is back for you, Dr. Wael. Thank you very much.
Thank you very much, Dr. Ala. Our next speaker will talk about multifactorial CV risk management in type 2 diabetes. Dr. Ronnie Shantufi is a consultant interventional cardiologist at the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. He specializes in intervention, but has a strong interest in preventative cardiology and well-being. Welcome, Ronnie.
Thank you very much. We'll go ahead and share our screen. All right, we can see the screen.
Yes.
Okay, great. So my name is Ronnie Shantouf. I'm one of the interventional cardiologists at Cleveland Clinic Abu Dhabi. And as Dr. Wael mentioned, I do have a strong interest in cardiovascular prevention along with intervention. And I think it's critical that we understand diabetes and the treatment of diabetes from a cardiovascular standpoint. I have no relevant disclosures for this talk. So the objective of my talk is going to be to highlight the burden of type 2 diabetes briefly. We'll update the cardiovascular risk assessment and prevention approach. We'll classify cardiovascular risk in diabetics. We'll emphasize lifestyle modifications as a primary driver of risk reduction in diabetes. Define treatments and targets for blood pressure management in type 2 diabetes. Define treatment and targets for lipid management, along with antiplatelet management, and highlight new type 2 diabetes treatments in relationships to cardiovascular disease modulation, which was beautifully highlighted in the previous talk. We'll emphasize A1C targets and relationships to cardiovascular complications, highlight recommendations in CKD, And a lot of the information is coming from the ESC, EASD guidelines on diabetes, prediabetes, and cardiovascular disease. So let's jump right in. So again, just a few highlights. The global burden of diabetic type 2 diabetes is growing. We are approaching 10% of the population in China and India alone with diabetes. About half of the 60 million Europeans are undiagnosed with type 2 diabetes. And by 2045, we estimate over 1.2 billion people will have either pre-diabetes or diabetes. And part of the emerging risk factor collaboration, this is a study that actually was a meta-analysis of 102 prospective studies, which showed that diabetes had a twofold increased risk for vascular complications. And there was an excess risk when we looked at women and those at a younger age. The Swedish National Diabetes Register showed that age at diabetes diagnosis, glycemic control, and renal complications were major determinants of cardiovascular outcome. Furthermore, elevated coronary artery disease risk starts below the cutoff of diabetes diagnosis, so below the 126 milligrams or 7 millimoles, and increases with baseline fasting glucose levels. So this is critical because it is important to understand that risk has already started. By the time the patient is a diabetic, they've already entered a higher risk category than patients who are not. And I actually find that using the term pre-diabetes is somewhat confusing to the patient. It makes them feel they don't have a certain condition. And I think it's important that we start the thought process earlier on in treatment. So here's a study looking at AMI patients. So patients who present with acute myocardial infarction. This was a 24-site US registry from 2005 to 2008. These are patients that presented. They were categorized into 3 different groups. Those with diabetes based on an A1C above 6.5, pre-diabetics, 5.7 to 6.4, and normal glycemics. Almost 3,000 patients, 38% of the AMI patients had diabetes, 31% of the patients had pre-diabetes, and 31% of patients had normal glucose metabolism based on this definition. So that's 7 out of 10 patients that presented with a major heart attack had dysglycemia. And so when we look at about treatment, and it was again mentioned slightly earlier in the talk that almost 50%, up to 50% of patients with diabetes do not meet the targets for glycemic, cholesterol, or blood pressure control. That's any of those targets. It actually is higher if we consider meeting all 3 targets. So it's critical to understand how to classify cardiovascular risk because this has become completely intertwined in the diabetic guidelines. And there are really 3 major classifications that one needs to consider. One is very high risk, a high risk group, and a moderate risk group. A very high risk group is based on a 10-year risk of death of 10% or higher. The high risk group is a 10-year risk of death, cardiovascular death, between 5 and 10%. And the moderate risk group is an estimated risk of under 5% risk of death over the course of the 10 years. So patients who have diabetes and established cardiovascular disease, and we're going to reiterate again what was mentioned earlier, or have one of the 3 conditions: target organ damage, defined as proteinuria, renal impairment, LVH, left ventricular hypertrophy, or retinopathy. Or they have 3 or more major risk factors defined as age, high blood pressure, or dyslipidemia. So again, that's not just elevated LDL-C, but that includes low HDL or elevated triglycerides, smoking or obesity, or early onset of type 1 diabetes of long duration greater than 20 years. Our high risk category are patients with diabetes duration of greater than 10 years without any of the target organ damage mentioned, plus any one of the other risk factors. And then our moderate risk group are essentially everyone else who are younger patients under the age of 50 for type 2 and under the age of 35 for type 1, and with a diabetes duration of less than 10 years without other risk factors. And so it's critical that we have these categories in our mind as we determine what is the optimal treatment approach for patients. And it's important to know that the risk of fatal cardiovascular events estimate at about the risk of non-fatal or fatal events estimate at 3 times the fatal cardiovascular event. In that a 10% risk of cardiovascular death translates into about a 30% risk of any ASCVD event. and as high as 4 times the risk in females. So let's go through each category. So blood pressure, it's important to individualize targets. So lifestyle changes are first and foremost in regards to hypertension. Medications are recommended if your office blood pressure is greater than 140 or 90. And our goal systolic blood pressure is to reach 130 millimeters of mercury, and if well tolerated, below 130, but not below 120. So our target zone is really between 120 and 130. If you are an older population, the target is slightly more lenient to 130 and 139. Your diastolic blood pressure target is less than 80, but not less than 70. And on treatment, overall systolic blood pressure should be less than 130. And consider this for patients who are high risk for cerebrovascular events or diabetic kidney disease. First choice is going to be RAS blockers, so ARBs or ACE inhibitors. This is greatly preferred compared to beta blockers or diuretics, and for blood pressure control, including pre-diabetics. It's recommended to initiate RAS blockade with a calcium channel blocker or a thiazide or thiazide-like diuretic, as opposed to a beta blocker if beta blocker is not necessary. And also it's a 2A recommendation to consider home blood pressure self-monitoring. And it's also a 2A recommendation for 24-hour ambulatory blood pressure assessment and adjustment. So that means as you're titrating your medications, it's not a one-time event to supply a 24-hour blood pressure monitor if your location has access. And a few key highlights. So hypertension consists of greater than 60% of type 2 diabetics. Long-term exercise training can actually reduce your systolic blood pressure by almost 7 millimeters of mercury and diastolic by 5 millimeters of mercury. And this is on average. And that's about as good as one blood pressure medication. It's important, again, to avoid beta blockers and diuretic combinations in pre-diabetics, as the combination actually favors the development of diabetes. So you just put your patients at a slightly higher risk to go on to develop diabetes. However, if you are to use a beta blocker, carvedilol and nebivolol potentially have improved insulin sensitivity with no clear negative effects on glycemic control. And so that may be a potential choice. Pre-diabetics, ramipril was noted did not significantly reduce the incidence of diabetes, but increased regression to normal glycemia, again demonstrating the effects of ACE inhibitor. And for glucose intolerant patients, valsartan significantly reduced the incidence of new onset diabetes. So what about lipid management? So again, keeping the risk categories in mind. So if you fall under the moderate risk cardiovascular group, your LDL-C target is less than 2.6 millimoles or 100 milligrams per deciliter. If you're a high risk cardiovascular category, your LDL target should be below 70, and you want to drop your LDL-C by at least 50%. So these are more aggressive targets than they have been in the past, and it's important that we keep that in mind, that we're not just starting patients on one anti-lipid medication and then seeing them again in 6 months to a year without titration. This is supposed to be an active approach to treatment for these patients. Very high risk cardiovascular patients, really our target is well below what it is compared to moderate cardiovascular risk, and we want to target less than 1.4 millimoles or less than 55 milligrams per deciliter. There is a secondary goal of a reduction in non-HDL to less than 2.6 for your high risk cardiovascular patients, and a secondary goal in your very high risk to below 2.2 millimoles per liter. I think we're going to see that come into play in future guidelines when we start to look at non-LDL lipoproteins such as VLDL and get a better understanding of these lipoproteins. So statins are the first choice for lipid lowering treatment with diabetics and high LDL-C. Now, the ADA, the American Diabetes Association, recommends a moderate intensity statin for diabetics above the age of 40 and below 75 without ASCVD. This is independent of what your LDL-C is. And they consider moderate intense statins for diabetics between the age of 20 and 39 without ASCVD. So again, this is where you're individualizing treatment and making a judgment in regards to starting your patients on a statin early on in life. I would, this is up for discussion, but of course, patients who have had long-standing diabetes, despite the fact that they are young, this might be something to consider in regards to moving towards a more aggressive approach when it comes to lipid lowering. If your LDL-C target is not reached, then the recommendation is to add ezetimibe And also it's recommended a PCSK9 inhibitor in very high risk patients who have persistently high LDL-Cs despite maximally tolerated statins or ezetimibe. In patients in the lower risk category, the expectation is that one should almost always be able to reach the targets for the moderate or high risk group with the combination of a statin and ezetimibe. However, if necessary, you will want to add a third agent. So there are common clusters of lipid abnormalities in diabetics. A lot of patients have low HDL, moderately elevated fasting and non-fasting triglycerides, an elevation of triglyceride-rich lipoproteins such as chylomicrons and VLDLs. And usually they actually have a normal to mildly elevated levels of LDL-C. And so we should not be thrown off by the fact that a patient may have a, quote, normal LDL-C. When you see dyslipidemia, and again, going back to our guidelines, dyslipidemia is really low HDL, elevated triglycerides or triglyceride-rich lipoproteins. These are patients that are at a higher risk category. And so patients, if you actually look at NMR profiling for these patients, you're going to see an elevated or predominantly small dense lipoprotein particles. So looking at a meta-analysis of 15,600 patients who had diabetes, statin-induced LDL-C reduction of 1 millimole per liter, or approximately 40 milligrams per deciliter, showed almost a 9% drop in all-cause mortality and a 21% drop in major cardiovascular events. Statin therapy associated with new onset diabetes, this is always a risk, and it's important to understand this when discussing with your patients. For every 1 millimole drop, you see about a conversion to diabetes at about increase of 10% in this patient population. So the risk of new onset diabetes increase with age, and it's confined, but it's actually confined to those at a higher age and those who already are at risk of developing diabetes. However, when you look in totality, the benefits in terms of cardiovascular event reduction far exceed the risk of statin therapy in regards to the developing diabetes in your pre-diabetics. So a subgroup analysis looking at out of Odyssey outcomes, these are patients with diabetes. The diabetics had double the absolute risk reduction versus pre-diabetics and non-diabetics. So the higher your risk, the more impact you saw, but we should consider this as exploratory data at this point. The Field and Accord study demonstrated the administration of fenofibrates on statins did reduce cardiovascular events. However, these are in patients who had both elevated triglycerides and reduced HDL-C. And so this is not a primary recommendation in the guidelines. It is still recommended to start with statin therapy, given the clear-cut morbidity and mortality benefit overall. Just a brief on antiplatelet therapy, the latest guidelines note to consider aspirin, low-dose aspirin for primary prevention in diabetics with high or very high cardiovascular risk in the absence of clear contraindications. This is only a 2B recommendation. And when we look at aspirin, it is not recommended in diabetics at low to or moderate cardiovascular risk. Concomitant use of PPIs, proton pump inhibitors, are recommended in patients with aspirin monotherapy, dual antiplatelet therapy, or anticoagulant monotherapy who are at high GI bleed risk. What about A1C? It is recommended for tight glucose control with an A1C of less than 7% to reduce microvascular complications. And we do like to target A1C of less than 7% to reduce macrovascular complications. Individualized A1C targets are based on diabetes duration, comorbidities, and age. So you have to take into consideration what are you likely to achieve in your patient that is sitting in front of you in clinic. And also to consider self-monitoring blood glucose to facilitate optimal glucose control. So a meta-analysis of 3 major studies, Accord, Advance, and VADT, showed that in type 2 diabetics, an A1C drop was associated with a 15% relative risk reduction in non-fatal MI without the impact of cardiovascular CVA, cardiovascular all-cause mortality. So we do see a reduction in MI rates, but not necessarily in other aspects of risk. The DCCT and the EDIC this is in type 1 diabetics, showed that long follow-up was necessary to show macrovascular complication benefit with early glucose control. So we are likely to achieve a reduction in macrovascular complications. However, it needs a longer duration of treatment time. A1C targets of less than 7% do show a reduction in microvascular complications, hence the class 1 recommendation. And with younger patients, a goal of 6 to 6.5% with a short duration of diabetes and no evidence of cardiovascular disease. So these are patients where you could potentially be more aggressive in regards to your treatment approach. The goals of A1C of less than 8% may be adequate for our elderly population or those with long-standing diabetes and limited life expectancy, frailty, or multiple comorbidities. These are patients that it might be hard to really undergo a significant polypharmacy. So glucose-lowering treatments. So your SGLT2 inhibitors are recommended in diabetics who also have CKD to reduce the progression of diabetes, kidney disease. SGLT2s are recommended in type 2 diabetics who have cardiovascular disease, very high risk for cardiovascular disease, or high risk. So again, these are the categories, and it's important to understand the categories. And the recommendation is to reduce cardiovascular events. In specific, empagliflozin is recommended for type 2 diabetics and cardiovascular disease to actually reduce risk of death. And this is largely based on the trial showing this effect. Your GLP-1 medications recommended for type 2 diabetics, again, those who have established cardiovascular disease, very high risk cardiovascular or high risk cardiovascular risk to reduce cardiovascular events. And specific medications have been shown to reduce the risk of death, again, based on specific findings in trials. Metformin, as mentioned earlier, to consider in our overweight patients with type 2 diabetics and who are at the moderate risk category. And so multiple trials mentioned here, and I'll just keep the slide for reference, strongly suggest that these medications not only impact, of course, blood glucose control, but also the likelihood of developing cardiovascular complications, and hence the strong recommendations that have come out of the guidelines in the last really five years. This is just a slide. It's a little bit tough to see, but again, for reference, that really kind of lays out the different medications in regards to these categories. So for chronic kidney disease, again, about 40% of patients with type 2 diabetes will go on to develop CKD. And it's important, and it's a class 1 indication for annual screening of both serum creatinine and albumin excretion. And your SGLT2 inhibitors have, again, mentioned associated with lower risk of renal endpoints and recommended in patients who have a reduction in GFR. GLP-1s with specific medications are associated with lower renal endpoints, and those should be considered for diabetic treatments if their GFR is above 30. What about OSA? This is not something that we usually think about in our diabetic population in our cardiometabolic clinic at Cleveland Clinic. This is part of our routine screening, given the strong association that we found with diabetics. And so symptomatic obstructive sleep apnea, the prevalence on average, and this is just the general population, is 2 to 4%, and that includes adults and children. It is, of course, an upper airway collapse that leads to sympathetic activation, systemic inflammation, and oxidative stress. So here's a study looking at diabetics, adults, 330 patients. The prevalence was as high as almost 50%. And when we looked at obese patients with diabetes, the prevalence almost reached 90%, so 86%. And obstructive sleep apnea is associated with an increased risk and severity of type 2 diabetes, independent of age or obesity. And treatment of obstructive sleep apnea with CPAP has been shown to cause a reduction in insulin resistance and improve glycemic control in pre-diabetics and type 2 diabetics. So it is important to also screen for obstructive sleep apnea, despite the fact that they may not be clearly outlined in the guidelines. And so what about risk assessment? Risk assessment in our patients, again, screening ECG is recommended. One can consider carotid or femoral ultrasound for plaque detection. These are patients where you have a high suspicion of patients having underlying disease. Consider ABIs for cardiovascular risk modifying. These are screening protocols that may actually change the patient's risk category. And one can consider coronary calcium scoring for a cardiovascular risk modifying. It is a 2B recommendation. And so while it's not recommended on a routine basis, it is something to consider in our patients. Coronary CTA, which is going to look more at soft plaque and what underlying obstructive disease, and functional imaging screening does have a 2B recommendation in the ESC guidelines, and should be used judiciously or carefully in select patient population. We do got to keep in mind this, for a coronary CTA, this is a contrast exposure, and with our patients having underlying CKD, it'll be important to have that understanding prior to committing them. It is not recommended to undergo carotid ultrasound intimal medial thickness for cardiovascular risk assessment. Now, what about looking for ischemia? Observational studies and randomized controlled trials discussing the prevalence of silent ischemia in asymptomatic diabetes, and randomized controlled trials evaluating the impact of routine screening asymptomatic diabetics have shown no difference in cardiac death or unstable angina. So that includes stress testing, coronary CTA when compared to current recommendations. And a meta-analysis of 5 randomized controlled trials depicted here on the left of the screen in asymptomatic diabetes showed that non-invasive imaging did not significantly reduce non-fatal MI, and thus routine screening is not recommended. However, one can consider it in very high-risk asymptomatic diabetes. Again, I think we have a higher risk patient population in the Middle East and South Asia, and we do need to keep that in mind when undergoing optimizing treatment for our patients. So what about prevention of cardiovascular disease in our diabetics and pre-diabetics? Lifestyle modifications are the most important driver, and lifestyle intervention is recommended to delay and also prevent the progression from prediabetes to diabetes. A meta-analysis looking at 63 studies showed that for each additional kilogram drop, we saw 43% lower odds of type 2 diabetes. And in multiple studies depicted here, including a 30-year follow-up, all supported lifestyle interventions that reduce the development of diabetes. In our diabetic patients, lower calories resulted in a fall in A1C. In the DIRECT study, which was an intense weight management program based out of Europe versus best practice, showed that 50% of participants were able to achieve remission to non-diabetes state and off of glucose-lowering medications. That is better than any medications that we are able to provide. And sustained remission was obtained at 24 months for greater than 33% of the patients who had type 2 diabetes. 70% of patients were still in remission if they lost more than 15 kilograms. And there are small studies and case reports that you can find in the literature and individual self-reports from different physicians and patients who have had a significant A1C reduction with either intermittent fasting or low carbohydrate eating patterns. And we've seen dramatic drops in A1C in individual cases. There's a case report in 2018 that showed a type 1 diabetic who with change in diet was able to reduce their A1C from 7.1% to 5.3%. So these are dramatic drops with nutritional and lifestyle changes that should be considered and first and foremost as a driver. Here's just a table showing the different recommendations in a more table format one can use for reference. And to sort of start to wrap up, multifactorial management is critical in taking care of these patients. So the STENO2 study, 160 very high risk diabetics, intensive target driven multifactorial treatment versus conventional with the aggressive treatment to hit all of the noted targets on the screen, showed a 50% reduction in microvascular and microvascular events out after 7.8 years, and long-term follow-up out to 21 years for end-stage renal disease and death reduction with a hazard ratio of 0.53. This estimated to a gain of almost 8 years of life. Dramatic when you really target all aspects of care. And so cardiometabolic treatment, ASCVD is the primary driver of morbidity and mortality in diabetics and is highly intertwined with diabetes, nutrition, and weight. And diabetes management needs to be viewed in a holistic fashion. Cardiologists must not view diabetes as an endocrine issue, and endocrinologists should not view cardiovascular disease as a purely cardiac issue. Nutritionists should not view cardiovascular disease as a doctor issue, and doctors should not view nutrition as a nutritious issue. This is really a team-based approach. Cross-communication among specialists and specialties is necessary, and patient participation and understanding, I would argue, is critical and absolutely necessary for optimal management. And so with that, we'll wrap up, and thank you very much for your time.
Thank you very much, Ronnie, for that excellent presentation. We'll now go to the case discussion of a case of cardiovascular disease and diabetes. It'll be by Dr. Ala and Dr. Hani. Dr. Hani is a consultant cardiologist and head of the Cardiometabolic Center at Cleveland Clinic, Abu Dhabi, and he has numerous interests, including diabetes, dyslipidemia, electrophysiology, and heart failure. Please go ahead. Please remember to put your questions in the questions and answers, and we'll try and answer the questions after this presentation.
Hi, everyone, and I'll be sharing Dr. Halim presenting this case. It's a case of Mr. Samer, who is around 56 years old. He is known to have type 2 diabetes for the last 15 years. He's also non-hypertensive for similar period of time, almost 10 years, and dyslipidemia for around 7 years. He has been on glargine 38 units, Janomet, that's sitagliptin and metformin 50 and 1000 twice a day. And he has been taking atorvastatin 20 milligram once per day. And for hypertension, he has been using amlodipine and perindopril combination 5 and 5 milligram. So Mr. Samer actually attended the cardiology department after sudden onset of chest pain and shortness of breath. The only significant history he gave is that he had a flu shot 2 weeks earlier. He didn't have any fever or cough, but he had mild leg swelling. He's non-smoker and he's non-ethanol consumer. Next slide, Rahani. Yes. Examination, his blood pressure is 100/60. His pulse is 98, regular, and he was afebrile. His BMI is around 28.5. Examination of the chest showed bilateral basal crackles, and cardiovascular examination showed S1, S2, and S3, but there were no murmurs. Abdomen examination was normal, and examination of the lower limbs showed lower limb edema. So he was further investigated, and we looked at his hemoglobin A1C. His hemoglobin A1C was 11%. So he's basically a high-risk patient with multiple risk factors, diabetes, hypertension, and dyslipidemia, but it seems to be uncontrolled with an A1C of 11. He had some microalbuminuria with an albumin creatinine ratio of 245, but his creatinine was normal, 0.9, with an eGFR of 87.6 ml per minute. So further tests showed, we did an ECG for him. The ECG showed diffuse T-wave inversion in all the leads. Cardiac enzymes were normal, but his proBNP was high, was around 1,500. His chest X-ray showed evidence of cardiomegaly, pulmonary congestion, and his CBC showed mild microcytic anemia. His LFTs were normal. So based on these findings, the significant or diffuse T-wave inversion in all the leads, the history of flu vaccine previously. So he was diagnosed as inflammatory myocarditis or post-flu vaccine myocarditis. He was started on dexamethasone treatment, and after starting the treatment, when the cardiologist started seeing his blood glucose levels, they found that his fasting blood glucose ranged between 162 to 250. And his random blood glucose, that's the POCT inside the hospital, showed a random blood glucose that is always above 300. Only single reading was around 140. So after starting dexamethasone, his blood sugar started to be very high. So they requested an endocrine opinion to see the patient. So I'll start with the first polling question, and we'll get the answers while we go around. So the first question is insulin still relevant in patients with type 2 diabetes in the presence of disease-modifying agents and combinations? If your answer is yes, click yes or no. You have 15 seconds. Okay, so around 86% of you said, yes, there is a place for insulin despite the availability of current medications. Okay, so next slide. So the next question is actually related to the management. So this patient fasting blood glucose was actually high, and it ranged between 160 to 250. And postprandial was around 300, 300 something. So the question is, what is the in-hospital blood glucose target? What does the guideline recommend? So this is the second polling question, and I'd like you to choose, is it 110 to 180, 140 to 180, 110 to 200, 80 to 200, or just anything less than 200? Okay, responses. So people actually were divided between 110 to 180 and 140 to 180. Around 42% answered number one and 44% answered number two. So let's go and see the guidelines. So this is a quote from the American Diabetes Association, the Standards of Care in 2020. And I'd like to start by first defining what is hyperglycemia in an in-hospital setting. Hyperglycemia is in an in-hospital setting is a blood glucose of more than 140. So if a blood glucose is more than 140 and is persistent, this is hyperglycemia. Now, should we treat at 140? No, the guideline would say insulin therapy should be initiated for treatment of persistent hyperglycemia starting at a threshold of more than 180. But once you start insulin therapy, then your target is 140 to 180. And this is recommended for the majority of critically ill patients and non-critically ill patients. Another goal or target, stringent goals such as 110 to 140 may be appropriate in selected patients who can achieve that without hypoglycemia. So those who answered number one are right, and those who answered number two are also right. So the target could be 140 to 180, or it could be 110 to 140. So next slide, Farhani. So my next question, again, another polling question. So this patient was basically on glargine and Janumet, and now he has been started on dexamethasone. We actually put this case because this is a very topical issue. We're seeing it almost daily on our wards, specifically with the start since COVID started, and since we started using dexamethasone for management of COVID, all patients are having very high blood sugar. So what's the best way to manage this? Should we increase this patient glargine dose or just add insulin boluses? Should we add an SGLT2 inhibitor because he had the history of myocarditis? Or should we add Humulin N on top of glargine? Or can we just add a pioglitazone? So you have 15 seconds to answer. Okay. So most of you have chosen number two, to add insulin boluses to his regimen, while around 13% have chosen to go for increasing the glargine dose. 28% suggested adding an SGLT2 inhibitor to his management because he had probably the element of myocarditis. So see, if we look at it, then we'll look now on the treatment. I will take you again through the guideline, and this is again the American Diabetes Association guideline. What they suggested, sorry, one back, yes, to start basal insulin or basal bolus with correction insulin regimen is the preferred treatment in non-critically ill hospitalized patients who has poor oral intake or those who are taking nothing by mouth. So basal bolus with correction dose. If the patient is critically ill or MPO, then the regimen could be basal insulin with brandial and correction doses. Again, is preferred for non-critically ill hospitalized patients with good nutritional intake. The use of a sliding scale is completely not acceptable. So the guideline says the use of only sliding scale insulin regimen in hospital setting is strongly discouraged. So basically, we're talking about use of insulin in patients with steroid-induced hyperglycemia. Now, this is the ADA guideline, and I'd like to take you to other guidelines. This is the British guidelines, and I have taken this just to show you the duration of action of each of the steroids when we use it for management in hospital. So hydrocortisone usually, and this is the equivalent dose, the duration of action has a short half-life, around 8 hours, while prednisolone acts for around 16 to 36 hours. So it's intermediate acting. Methylprednisolone has similar probably duration of action, a bit longer than prednisolone, but still would say intermediate duration of action. While dexamethasone and betamethasone has the longest half-life, and they stay for almost 54 hours in the circulation. So putting that in mind, this is a recent paper in 2020 that has been published to handle the management of steroids in hospital, steroid-induced hyperglycemia in hospital setting. And they tried to sketch the response, the glucose response to steroid injection. So if a patient took hydrocortisone, which is short-acting, what we would expect if he take it in the morning, it starts working in 1 hour, it peaks in 3 hours, and the effect resolves in around 6 hours. So this is the way you would look at the glucose profile. You will see a peak, and then it comes down over 6 hours. If hydrocortisone is being taken twice, you will see 2 peaks that each of them is around 6 hours. Now, if a patient used intermediate acting steroid like prednisolone and methylprednisolone, so they start action after 4 hours, and they peak in 8 hours, and they continue working up to 16 hours. So probably you'd see a double hump effect all through the day if they took it twice a day, or you will see the effect with sort of a plateau over 12 hours period. And if the patient took a long-acting steroid like dexamethasone, it continues for almost 48 hours. And I would expect that my patient will be having a high blood glucose all through the day. There is no peak and there is no nadir through the day. So if we put this in mind, the same paper has suggested actually a very nice algorithm. But before that, I'll take you to the British recommendations. They said if a patient developed steroid-induced hyperglycemia, then there are a few things that you need to look. Number one, you need to monitor their blood glucose regularly, and you set a target for those patients. And you need to consider increasing the monitoring up to 4 times daily. So you don't get satisfied with a single reading a day. You need to do it at least 4 times a day. So the number of SMBG will increase, and then you need to refresh patients' education. If there is hyperglycemia and the patient is not on insulin, then you can start gliclazide or metformin, and a secretagogue and an insulin sensitizer. If the patient is already on insulin, then if on evening once daily Humulin N, you can switch it to the morning to cover the morning surge. Instead of making it in the evening, shift it to the morning. If the patient is uncontrolled with hyperglycemia or multiple daily doses, then probably you might need to go for insulin analogs and go for basal and bolus regimen. you need to be aware of nocturnal hypoglycemia, because that will be probably the lowest levels of steroids, because you start taking it in the morning, overnight, and you give your patient extra doses of insulin, they might develop nocturnal hypoglycemia. So this is what the British say. What about the suggested algorithm? And I like this algorithm very much, because it actually looked at the patient's glycemic profile. So if a patient has been started on hydrocortisone, for example, which we said it has a duration of action of 6 hours. So this patient, once being started on prednisolone, you will see that peak, then you don't need to start him on a long-acting insulin. You can straight go for a bolus or rapid-acting insulin at a dose of 0.1 unit per kg. Okay, and if the patient received the hydrocortisone twice, you can give 2 boluses during the day. Now, this is how to initiate the treatment. How can we adjust the treatment if the blood sugar is still high? What we can do is we check the blood glucose at noon, and if it is more than 200, then we can add a 0.04 international unit per kg, or we can increase it to 0.08 units per kg. If the patient is still having very high blood glucose level, then we can add a basal insulin. Now, if the patient has been started on an intermediate acting insulin like, steroid like prednisolone, then I would expect that to go for 12 hours. Then I will go for an intermediate acting insulin like MPH. And I can use MPH with a dose of 0.2 international unit per kg. If the prednisolone dose is less than 40, I can give a higher dose, 0.3, if the prednisolone dose is more than 40 milligram. And I would consider insulin glargine if the patient is taking prednisolone more than once a day, or if the units are too high. This is how to initiate it. I can increase the doses by checking the noon blood glucose, and I could consider an MPH twice daily to match the surge in blood glucose. How would I intensify the treatment in those patients? I can add rapid-acting insulin to Humulin N, or I can give a premixed insulin in the morning to cover the surge or the rise in blood glucose at that point. Now, finally, if we had a patient who has been started on dexamethasone, which is has a slow decrease and it has a lower peak and has a longer duration of more than 24 hours. In those patients, I can start an intermediate acting insulin twice a day, or I can use an ultra long acting insulin. And the dose is 0.3 milligram, 0.3 units per kg, or 0.2 to 0.3 if I use an ultra long acting insulin. I can check the blood glucose, and I can add later boluses based on the blood glucose levels. So that's how I adjust the treatment and how I intensify the treatment. So back to our patient, the patient insulin dose has been increased, his medications has been adjusted. He remained in the hospital for almost 7 days, and he recovered completely. However, 1 month after discharge, and he was supposed to have a full recovery, he attended the emergency again with similar symptoms, which is difficulty in breathing, paroxysmal nocturnal dyspnea, lower lymphedema, and his heart rate was high and his blood pressure was low. So, Dr. Hani, what do you think happened to this patient? Why did he come back to the hospital after this much period of time?
Thank you very much for this really outstanding review. So this is the complexity of the case, because he has cardiometabolic disease, and the transition from the inpatient to the outpatient may have been managed in a little bit better way to avoid a hospital readmission. As we all know, the hospital readmission is a marker of heart failure and worsening. So traditionally, the patient would be discharged to the cardiology clinic or the heart failure clinic within 14 days. Now we have to consider what happens if this appointment was missed. What's the impact on mortality if we have the 7 to 14-day post-discharge appointments? In fact, this has been established in the ACC and the European guidelines that you need to have this early follow-up, either a phone call or a physical follow-up, so that you don't fall into this vulnerable phase where the mortality is greatest. Now, the routine follow-up in the endocrinology clinic would be expected to be done in 3 months, right? And in fact, if you go to a medication refill visit, typically with an EMR, people will just click the button and refill all medications without reviewing what's going on. So the problem here in a conventional approach is going to be no systematic medication review and reconciliation, no review of the new medications, no opportunity to review or explore side effects in detail. And then, of course, everybody's in their own bucket, right? We can only fill the cardiac medications in the cardiology clinic. We can only fill the diabetes medications in the diabetes clinic. And of course, there's other medications too, hypertensive medications, lipid-lowering agents, PPI in patients with high bleeding risk. And of course, the other thing is about lab tests. So this patient was just discharged. The front desk is going to tell the patient the insurance won't cover. We do the labs every 3 months because there's no recognition of the acute involvement and the fact that he needs more comprehensive care as well. So the traditional approach, unfortunately, is patients are managed in silos in separate non-integrated clinics, right? So if the patient ideally was scheduled for the cardiology clinic appointment 7 to 14 days after discharge with the labs, the patient's appointment was confirmed by the clinic nurse. However, he missed the appointment. So he comes into the clinic urgently 3 weeks later, which is 5 weeks after discharge, for medication refill, stating urgently, I ran out of medications. He's seen very briefly by the resident or somebody, and then the cardiac medications were just filled unchanged by the resident, and steroids were not tapered, labs were not done, and in fact, in the notes, it would say, refer to the endo or diabetes clinic to refill his diabetes medications, right? That's the traditional approach.
Yeah.
So the patient did feel better, was discharged again from clinic, and then of course, when he goes to the diabetes clinic from the heart failure clinic, he walks in again to the diabetes clinic based on the referral. He states to the nurse he just needs the medications refilled, and he has another appointment booked from before his admission in another 2 months, and he needs to get back to work. So he will do the lab tests in 2 months with a routine visit. The clinic is very busy and is about to leave. In the corridor, he's actually seen by Dr. Ala, who remembers him from the inpatient, and recognizing the problem immediately enrolls the patient into the cardiometabolic pathway. He's now sent immediately to the lab, and detailed evaluation of the biomarkers and medications is done. So at this point,
Yeah, actually, Dr. Hani, when I've seen him, I examined this patient, and I found that his blood pressure is lower side, 100 over 60. He was a bit towards tachycardia with a pulse of 98, but his pulse was regular. Again, he had basal crackles. He had evidence of heart failure, and he was having lower lymphedema. So he was already on Lasix, so we doubled actually the dose of Lasix, and then we requested a couple of tests for him. We reviewed actually the previous test we did while he was in hospital. I remember that the ECG was showing a diffuse T-wave inversion. His troponin was normal, but this time his proBNP was actually higher. It was 1,500. It's now around 2,500, and the X-ray remained the same with cardiomegaly and pulmonary congestion. So we repeated the A1C again. It was around 11. Now it's around 9%. His albumin creatine ratio has improved, actually, probably because of the improvement in his glycemia. But his creatinine has increased. And we wondered, is it actually an actual diabetic nephropathy or just a cardiorenal syndrome where, because of the reduced ejection fraction, probably he is developing an element of renal impairment. The second proBNP, 2,350, and we referred him. I spoke to the cardiologist. They actually repeated they did an echo for him this time. And you can comment, Dr. Hani, on the echo. Dr. Hani, I think you're muted. Dr. Hani, you're muted.
Thank you. The ejection fraction is showing on 40 to 45%. The RV and the LV are both dilated. The ejection fraction as I mentioned, is somewhat reduced. There's also diastolic dysfunction grade 2, and there's elevated left atrial and filling pressures. So clearly a patient with LV dysfunction and also elevated filling pressures as well.
So could this be still remaining myocarditis, or after this period of time, we can probably change a diagnosis to a vaccine-related inflammatory cardiomyopathy. He definitely has uncontrolled diabetes with renal microvascular complications, definitely. But what do you think of the cardiac diagnosis?
So the patient had an extensive workup while he was in the hospital and subsequently, and he didn't have any evidence of coronary artery disease and no evidence of acute viral illness. So this is probably the inflammatory cardiomyopathy that occurs rarely after vaccination. We don't want to scare everybody, but it is an entity that we see. And it's also possible that the patient had a preceding diabetic cardiomyopathy that was unmasked by this intercurrent illness.
So, Dr. Hani, if I would ask, when we look at all cardiovascular outcome trials and trials in heart failure with SGLT2 and other medications, they're all focused on patients with ischemic heart disease and ischemic cardiomyopathy. Is there any role for the SGLT2 inhibitors and GLP-1 in patients with non-ischemic heart disease? I'll give this question as a polling question first, then we'll ask Dr. Hani. So let's ask the audience. Please vote. Do you think it has a similar role as in ischemic heart disease, or it is not indicated in non-ischemic heart disease, or you don't know? Can we set a polling question, please?
So while these polling questions being set up, I think we know that most of these patients who are enrolled in the SGLT2 and GLP-1 studies, actually the majority had coronary artery disease, right? So the EMPERIC outcome study, 100% of the patients had ASCVD and 75% of the patients had prior myocardial infarction or prior stroke. Similarly, in the LEADER study and the HARMONY study. In the dulaglutide study, the REWIND study, as well as the CLARE and CANVAS, there was a robust proportion, somewhere between 40 and 60%, who were not known to have ASCVD. So the question, of course, is what is the thing we're trying to target? Are we trying to target heart failure? Are we trying to target ASCVD? Are we trying to target both? So the studies were not designed, in fact, as heart failure studies. So as far as we can tell, in ischemic heart disease, the SGLT2 inhibitors exert an effect on MACE, and this is specific to the empagliflozin, in patients who had a prior infarction. And in the DECLARE study, also in patients who had a prior infarction, so the magnitude of benefit is a little bit smaller. The vast majority of the benefit, of course, is in heart failure. So since we've given you an answer, I think the polling question should be 100%, if people can go ahead and vote.
So let's see your opinion, and you have 15 seconds. Okay. Yeah, we had around 86, actually 66%. They thought it has a similar role as an ischemic heart disease, while 19 and 16% they didn't know.
So I think the data for GLP-1 receptor agonist is much more robust. It's very clear that the GLP-1 receptor agonist acts through the ischemic pathway on the endothelium, on the vasculature, in terms of atherogenic events. That's why they have a very potent effect on stroke. And in fact, the SGLT2 inhibitors don't really have any good effect on stroke. So I think we have to determine if we're dealing with coronary artery disease or with heart failure. However, what about the patient who has non-ischemic cardiomyopathy? Well, that patient actually has heart failure. And if they have heart failure, then the benefit is going to go obviously to the SGLT2 inhibitor class. Although this was not, they remember, were not specific outcome studies. In the sub-analysis of the DECLARE outcome study, it was fairly clear that whether the patients were ischemic or non-ischemic, the benefit in heart failure was fairly tremendous. So the evidence-based heart failure therapies are tremendous. We've had studies going back from the 1980s showing the benefits of valsartan, hydralazine, beta blocker, ivabradine, eplerenone, and more recently in the VERISIG-WET study with Victoria and valsartan sacubitril. This is heart failure with reduced ejection fraction. Now the SGLT2 inhibitors, starting with EMPERIC, go on to have a lot of cardiovascular outcomes. So we have the EMPEREG, CANVAS, DECLARE, and CREDENCE. We also have specific heart failure studies, which is the DAPA-HF, EMPER-REDUCE, and the less well-known empatropism study, which we'll discuss, VIRTUS-CV, and finally SCORED, which looked at a slightly different population of heart failure patients, including some HFpEF patients. So looking at the data for ejection fraction, because I think that's important, and this is causing a little bit of confusion in the world. So first of all, what is diabetic cardiomyopathy? So diabetic cardiomyopathy is what's called inflammatory metabolic cardiomyopathy or diabetic cardiomyopathy. This is a situation where the ventricle becomes stiff, thick, and fibrosed. There's infiltration with proteins and glycosylated proteins as well, resulting in LVH. There's reduced stiffness and elasticity of the ventricle is reduced. The left atrium therefore dilates, and you almost always have diastolic dysfunction. From a pathological standpoint, there's myocyte hypertrophy and fibrosis, perivascular fibrosis that's very intense, and also myocyte hypertrophy. And this is a diabetic patient who died with heart failure and didn't have coronary heart disease, but had severe heart failure. Now, the most important thing to remember about the diabetes outcome studies, the EMPEREG, CANVAS, and DECLARE, is that these are not heart failure studies. They're cardiovascular outcomes. So we're looking at broad varieties of cardiovascular outcomes, MI, stroke, heart failure, death. And in fact, less than 10% of these patients in all of these studies had HFrEF with an ejection fraction of less than 40% and clinical heart failure. The majority had cardiovascular disease or risk factors. So in fact, for these medications to reduce heart failure means that it is working at the tissue level to actually prevent heart failure in the first place. If you look at the DECLARE outcome study, this is one of the largest, in fact, it is the largest, and in fact had the largest number of patients who had an ejection fraction. The minority of patients, were actually less than 5%, had reduced ejection fraction. With a history of heart failure, 1,316 patients, again, over 45% were patients with heart failure. So it actually seems to be preventing heart failure in patients with reduced ejection fraction, and also by extrapolation in patients with preserved ejection fraction. So really prevention of heart failure, and therefore most of the heart failure must have been missed or misdiagnosed. Now, looking at the guidelines for heart failure, I think the key point to remember is that the guidelines require multifactorial treatment. Mortality is the standard 2-year mortality in an untreated heart failure patient is 35%. Adding the ACE or ARB reduces that by 23%. ARNI replacement is 16%. Beta blocker and MRA and aldosterone antagonist 30%. And the SGLT2 inhibitor gives you a significant relative risk reduction of 17%. So overall, the mortality in 2 years, if you apply all of these heart failure guideline therapies, will go from 35% to astounding 9.1%, with an absolute risk reduction of 25 and a number needed to treat of only 3.9. The relative risk reduction is 74%, considering a lethal disease with a very high mortality. So the combination is really written in stone. And this is really in graphical terms what happens if you add the ARNI to an SGLT2 inhibitor and you replace the ACE and the ARB. Now, this has actually been looked at in modeling studies, and the projected impact on a 55-year-old patient with reduced ejection fraction, if you give them only a RAS blocker and beta blocker, this is their conventional mortality. But if you give them all 4 therapies together, that's the beta blocker, ACE, MRA, ARNI, and SGLT2 inhibitor, the comprehensive therapy reduces improves the survival to 17 years with a difference of plus 6.3 years. So it's a very powerful addition. And what has been proposed by the people who write the guidelines and know this very well, instead of doing the sequencing where you do the ACE, beta blocker, then the ARNI and the MRA and the SGLT2, taking a long time, estimating about 6 months to get to all of these medications, is to actually start with beta blocker and SGLT2 inhibitor, put the ARNI or the SGLT2 inhibitor early, it doesn't matter, and add MRA. Do each step 1 week apart, and with that, you get all of the medications on board, at least at some dose, and then you can really advance your therapy more effectively. Now, one of the important things to realize is that the trajectory of heart failure is not stable. In the initial phase of heart failure after admission, which is what happens with this patient, the focus is decongestion. High doses of diuretics improve the patient. As they improve, they sort of stabilize, they switch from IV diuretics to oral diuretics, and then they're discharged and followed up. Now, most of the studies that we have talked about, DAPA-HF, EMPER-REDUCED, EMPER-PRESERVED, are actually guideline medical therapy in the outpatient setting at first follow-up. However, these studies, which are still ongoing, are looking at heart failure as well. So the DELIVER, this is the soloist heart failure study, And this is really one of the earlier phases of data for acute decompensated heart failure. So one of the things to look at is that the soloist study was actually a study with this novel drug called sotagliflozin. This is an SGLT2 inhibitor, which is also an SGLT1 inhibitor. The difference is in the GI tract. And here, they actually looked at this phase in the acute heart failure at the time of discharge, pre-discharge oral therapy optimization with reduction of basic doses, starting the sotagliflozin early, adding ACE/ARB or ARNI early. So this is the window here in blue, much earlier than what was initiated in the DAPA-HF and the EMPEROR-Reduce study. And in fact, they didn't actually look at the ejection fraction. They actually used this medication regardless of EF. So it tested two new hypotheses. Early in the acute phase, safe or not. Number two, in ejection fractions, low, medium, and high. And we're going to go through this. Now, the ejection fractions in most of these studies, as I mentioned, the DECLARE, the CANVAS, CREDENCE were all normal. EMPEROR-Reduced and DAPA-HF had reduced ejection fraction. The outcomes were tremendous. Reduction of CV death, reduction of renal failure, reduction of heart failure hospitalization, and low risk of adverse events. So the soloist heart failure study was designed to test two things: timing of initiation of an episode of decompensated heart failure, one. Number two, these patients are vulnerable because you're giving them high doses diuretics, and we're afraid of hypotension, precipitating renal function, also other drugs that affect GFR. So the safety of initiating shortly after an episode was not previously studied. And as we mentioned twice now by the previous two speakers, the use of SGLT2 or GLP-1 in patients with established CVD or diabetes with cardiovascular risk is well established. Now we want to see the timing and can we use it in the vulnerable phase. Now this is the amazing part of this study, is that used with patients in ejection fraction less than 50% or ejection fraction more than 50%, still a significant difference. In fact, most of the difference was driven by the patients over 50%. Now, if you broke the patients down by 40 to 50 or 50, it's still the same. If you went for less than 40 or greater than 40, it's still the same. The benefit is there in prevention of the primary endpoint, whether the ejection fraction was normal or reduced or in whatever way you wanted to cut it up. So the soloist study tells us two things: that more upstream use of SGLT2 inhibitors earlier, and especially with this agent, which is a 2-1 inhibitor and worsening heart failure, the hospitalization is a markedly important inflection point, and therefore you need to titrate or start medical therapy, and failure to initiate is a major missed opportunity to reduce mortality and morbidity. In hospital initiation is actually an independent predictor of better outcome and adherence. Now, the guidelines suggest that if you look at most of the HFrEF patients would actually also benefit from SGLT2 inhibitors, but as we have seen before from Dr. Ala's talk, only 10% of patients who are eligible are actually getting this, diabetics and non-diabetics. Now, we have a lot of success from this class of agents, in addition to vericiguat, ferric carboxymaltose, and the new medication, which I can't pronounce, which is a motility medication that improves the cytokinetics. However, we still have a lot of choices, and now the important point is to integrate, optimize, and overcome inertia, because that's what's the problem. We have a lot of treatments, we're not adopting them even though they have a mortality benefit. So the primary outcome of the study was heart failure, hospitalization, CV death together, and the urgent visits were reduced by a factor of 33%, and significant. If you look at the other endpoint of heart failure and urgent hospitalizations, again, reduced by almost 36%, and CV death was also reduced, but not significantly so, numerically less. So, Dr. Ala, since you asked me this question, what if this patient had a normal ejection fraction, HFpEF? What is the data for an SGLT2 inhibitor? So I'm going to try and answer this question here. So there's a lot of studies that are looking at HFpEF, and we've seen the Paragon study where valsartan sacubitril was used. So it was still approved though for HFpEF for reduction of heart failure hospitalization. Now, this medication here is called Aspirin. It's an anti-fibrotic agent that's used in patients with IPF. There's an ongoing trial right now. There is a sotagliflozin, which we mentioned, that showed benefit in type 2 diabetes and heart failure, including HFpEF, and the trial was truncated. We have EMPEROR preserved, which is still pending. We have the DECLARE study, And we also have this new agent, which is called finerenone, which is a mineralocorticoid antagonist that is used in patients with EF over 40%. Again, that's coming out very soon. So the other point that comes out of the soloist study, and I think I'm talking about this a lot because it's really the only randomized evidence about HFpEF and acute early initiation. The study showed a significant improvement compared to placebo within day 28 of follow-up, and the curves separate and become significant almost immediately and continue to increase by 33%. Now, the other subgroups, we mentioned the ejection fraction, whether the ejection fraction was normal or not, still benefit. If the patients were in North America or not, still benefit. If it was given early, before discharge or after discharge, there was no benefit, and no difference in benefit, still beneficial. Males or females, age, and whatever the GFR was advantageous. So there's a significant advantage, and to the left of the line of identity here by about 30%. Now, looking at the ejection fraction, because I think that's the magic question here, in patients with EF over 40%, there was an absolute risk reduction of 11.6 events and 9 number needed to treat. Very robust in patients with above 50%. In patients with middle range ejection fraction, 40 to 50%, 40% reduction, absolute risk reduction, 15, number needed to treat 7. Extremely robust reduction. Of course, as the ejection fraction drops, the improvement is going to be greater. So, Dr. Ala, if you'd like to come back to the treatment of the patient.
Yeah, actually, Dr. Hani, the patient has been started on an SGLT2 inhibitor, and we have adjusted his insulin doses, but we continued on Janumet twice a day. And we have added for him an ARNI, the sacubitril valsartan, twice a day, and a bisoprolol 5 milligram daily. We have added as well spironolactone 25 milligram and furosemide. He responded beautifully. Actually, he was discharged and he was completely asymptomatic. His A1C actually has improved, and this is a picture of his follow-up echocardiography. The first one was showing a reduced ejection fraction of 40 to 45, and you can tell me about the follow-up study, Dr. Hani.
So putting them side by side, I think, is a helpful way of looking at this. There is a difference in the ejection fraction, and using 2D and 3D quantification, the ejection fraction had improved by about 5 to 6%, which is something we know from the heart failure studies with certain sacubitril in particular. The filling pressures were reduced, and the IVC was certainly less dilated. And you can imagine that the LV, I don't know, we have the measurements here, but the LV diastolic dimensions are certainly improved as well. So there's certainly evidence of remodeling with heart failure and SGLT2 inhibitor therapy. So to conclude, this is a complex case, and we looked at the transition from the inpatient to the outpatient in a patient who was not effectively managed and managed in separate groups. And once he was in the cardiometabolic space with a cardiometabolic physician and a cardiometabolic mindset, the traditional approach was switched to the cardiometabolic approach. The frequency of visits was increased. Of course, we need to do every 7 to 14 days while you're titrating. We also do sequential follow-up monthly at least. There's also nurse visits and call-ins weekly to check on the patient's status. So that's the support you get from the cardiometabolic clinic. The diabetes educators also get involved. There's additional support mechanisms. We added cardiac rehabilitation, and these are 2 to 3 times a week with 12 weeks. The mechanisms have a built-in mechanism to support how do we engage the patient, how do we maintain the patient within this process. And I very much like Dr. Ala's initial lecture about the complexity of the treatment regimen when you send the patient home with 10 medications. There are also pharmacological interventions. We discussed here that the RCTs did not enroll acute patients except soloists and scored, and the published studies did not publish HFpEF, and now we have some data towards that. We also need to manage polypharmacy and acute medications and side effects. We also, as Dr. Ronnie very nicely mentioned in his talk, setting multi-parameter goals and targets and aggressive timelines for achievement. Typically, we'd like to get all of these targets within range within 12 weeks. And in this complex case, there's bidirectional positive reinforcement using the cardiometabolic process on multiple dimensions simultaneously. So there are behavioral interventions that emphasize the urgency and complication prevention, not just the A1C, not just the number of the LDL, plus encouraging physical wellness, as was very nicely shown also in Dr. Ronnie's lecture. In dietary interventions will address both heart failure restrictions and metabolic restrictions. Cardiac rehab will focus on regular physical wellness, weight and activity, quality of life, and positively reinforces behavioral and dietary interventions at the same time So the physician, the cardiac rehab, the nurse, the nutritionist, everybody's saying the same thing. Then the frequency of cardiac rehab 2 times or 3 times a week is linked to achievement of metabolic goals, blood pressure, glucose monitoring, and weight loss, because that's what happens in cardiac rehab. You keep tracking these things, and the patients have this little booklet where they're coming down on their weight, improving their blood pressure. You give them positive feedback and encouragement. Also, step count out of the clinic, lipid goals, and compliance with medical visits. Again, smoking cessation is constantly reinforced by all the team members at every visit. So there's a lot of elements, including the medical, physical, wellness, exercise, and nutrition that are emphasized multiple times at a time. Dr. Alan?
Yes, I think that was the final slide we had, but there is one comment I would like to add here, because we didn't actually allude to the GLP-1, and I'm aware that we have a lot of cardiologists attending this presentation, and I'd like just to give like 2-minute tips on how to start the GLP-1 and how to, avoid the side effects. In general, the main side effect of the GLP-1 is the GI symptoms, which is nausea and vomiting. What we usually do when we start patients on GLP-1, I guess the first thing we warn them about the side effects. We ask them to eat half of their portion of food they used to eat earlier, and we ask them to drink enough fluids. These are very important. So eat half of what you usually eat, drink enough fluids. And from our side, what we usually do is we start with up-titrating the dose. If we're going to start with liraglutide, we're going to start with 0.6 milligram, then 1.2 milligram for maybe 1 week or 10 days. And then we go for 1.2 milligram for another 1 week or 10 days. And then we go for 1.8 milligram. So if this is the way we're going to do, let's assume a patient has been on 1.2 milligram, and then we ask him to increase the dose to 1.8 milligram. If he started having nausea and vomiting, then we ask them to down titrate the dose to 1.2 milligram for a longer period of time until the symptoms of nausea and vomiting disappear, and then they can up titrate the dose to 1.8 milligram again. The use of GLP-1 is extremely safe and easy. We just need to properly educate our patients. So that was the comment I wanted to conclude the case with. And the mic is back to you, Dr. Wiley.
Thank you very much for that interesting and very complex case. As you can see, these patients can be extremely complex with a lot of polypharmacy and require a multidisciplinary approach, preferably in a cardiometabolic setup. We have some questions here. First, my colleague, Dr. Mustafa from Shamri from Saudi Arabia, always active with us. Is the SGLT2 effect a class effect on the cardiovascular benefit? Please unmute yourself. Unmute yourself.
Yeah, thank you, Dr. Mustafa. See, what we have noticed earlier with the GLP-1 studies, that we noticed that some of the GLP-1s had beneficial cardiovascular effects with improvement in cardiac outcomes, while others did not. We initially thought that might be a class effect, but it failed to prove that this is a class effect. Now with SGLT2 inhibitors, the differences are minor. All have cardiovascular benefits, specifically in heart failure, as well as in other cardiovascular outcomes. The differences might be related to the different design in the study, but we cannot claim that until we have more data from the SGLT2 inhibitors. But it seems to be the differences are mostly related to the different design of studies.
Okay. One of the colleagues here is up to date with the literature, and he asks about GIP with GLP-1 receptor agonists. Do you want to answer that, Dr. Bashir?
The GIP, actually, there are very early studies on it. There is no many medications actually out in the market. What we have currently is mostly a GLP-1 agonists with different, the latest is an oral semaglutide, but it's not available yet, and there are no enough studies on it.
Correct. Hani, I'd like to ask you, when would you recommend to our colleagues here, when should you order BNP?
So the BNP is actually fairly straightforward. It's incorporated in the ESC guidelines from 2019. We didn't have time to go over this, but if you have a diabetic patient who has symptoms of exertional fatigue, lower limb edema, not just overt dyspnea, and they have an abnormal ECG or a history of hypertension or a history of myocardial infarction, we've noticed now that almost 50 to 60% of diabetic patients actually have this diabetic cardiomyopathy we've described. So the ESC guideline is actually very specific. In that situation, anybody who's seeing a diabetic patient with these risk factor symptoms or ECG abnormalities should order a BNP, because that actually triages to an echo. If the NT-proBNP, the cutoff point is totally different than the acute heart failure setting, right? It's actually 125 with a very powerful sensitivity and specificity. If it's below that, the likelihood of heart failure is very low, even in the obese metabolic syndrome patient. If it's over 125, heart failure is very likely, an urgent cardiology consultation and an echo to define if they are reduced ejection fraction or improved ejection fraction. Now, the objective of doing this isn't just diagnostic. We know from 2 studies, Pontiac and STOP-HF, that using a BNP targeted strategy, you would add a RAS blocker, improve their RAS blockade, add an MRA, and in this era also adding SGLT2 inhibitor would actually reduce mortality and morbidity. So as we are also, I don't know if we can give a pitch to our ADOPT study, I think that's the same concept. You can early diagnose in the outpatient setting very cost effectively with a test that costs basically about 200 dirhams. If the patient has heart failure or not, triage them. Now, if they have the same symptoms and the BNP is low and they have an abnormal ECG, what does that mean? They may have coronary artery disease or anemia or morbid obesity, right? So it is actually very helpful. And I think this guideline is not particularly well adopted or even well known.
Thank you, Hani. Ronnie, which patients would you order a stress test in, and which patients would you order a calcium score?
Yeah, that's a great question. I think very high risk patients. So if they have multiple risk factors, they have severe uncontrolled diabetes, I think it's very reasonable to move forward with a stress test, given the concern that these patients may not express symptoms as well as more well-controlled diabetic. A calcium score, so they're not mutually exclusive. So, there might be patients where you're going to order a combination because it depends on your question. So if your question is, does the patient have underlying coronary artery disease? I think a calcium score can answer that question very well. If they do have calcium, they have underlying coronary artery disease. It may not be obstructive, but it does represent that there is a disease pattern that has started in the coronaries. And so it's important, you don't use a calcium score for symptomatic patients to make a decision, whereas a stress test might be something where you use it for somebody who has symptoms. Now, whether or not to order a calcium score is going to depend a little bit on your patient that's in front of you. If it's not going to change management, you may not order the test. If it's somebody that you are a little bit unsure of in regards to what risk category they're in, a calcium score can be very helpful. What we've found anecdotally is that, patients have a high burden of coronary artery disease here. And so, having a 40-year-old is not a guarantee that you're not going to have underlying disease. And so I think if you have uncontrolled diabetes, if these patients have advanced symptoms, they have advanced diabetes, then to better risk classify them, it is reasonable to use it. I think the important thing is to understand what to do with the information, and not to the key issue is the calcium score does not tell you anything about the likelihood. Well, I should say it doesn't tell you whether or not the patient has obstructive disease. It tells you whether or not they do have disease. Now, there is a correlation. If they have a calcium score that is extremely high, then the chance they have obstructive disease goes up.
Excellent. There's a question here about euglycemic DKA. How common is that with the SGLT2 inhibitors, Dr. Bashir?
It has been reported in many in early studies where we thought that probably is a wrong selection of patients for the SGLT2 inhibitors, but it has been proved that patients who has severe hyperglycemia and glucotoxicity who are not on insulin are likely to develop euglycemic DKA. So we do recommend using SGLT2 in patients who are not insulin deficient and who are not glucotoxic.
Okay. There's a question here, maybe Bashir, that you can see it as well.
Can I just make a small comment about this euglycemic DKA?
Yeah.
We didn't have a chance to mention this in the presentation, but if a patient is admitted to a hospital or has a acute event where they're NPO or something like that, then that's the kind of patient who should not be getting SGLT2 inhibitors or metformin because they are NPO, they're insulinopenic, they're more likely to have acidosis for other reasons. So I think this is the key point. If people are not familiar with this class of drugs, that's the patient where, you know, you gotta suspend it until they're able to go back to their normal diet, because that's the way to actually create this situation. It's usually iatrogenic rather than spontaneous.
There's one question here, Dr. Bashir, about using bolus in those who are not eating well versus sliding scale.
Actually what I've shown in the suggested algorithm that if the ADA guideline in last year in 2020, they did suggest using basal insulin as well as small boluses with correction doses in patients with who are not eating well or MPO. So basically, that what we should do. It should be used with a correction dose, a small bolus with a correction dose based on the patient intake and blood glucose level.
Hani, the question here about, you mentioned at least 5 medications for heart failure, but what if you were only able to use 2 or 3, which medications would you choose?
Why would we only be able to use 2 or 3? I mean, in clinical practice, you don't have that kind of scenario, right? So in order of maximum benefit, let's just make it very practical. Beta blockers, right? Number 1, you can't go without them in heart failure. If you're going to have a RAS blocker, you better go with ARNI because an ARNI contains valsartan as well as the sacubitril. So you're getting 2 in 1. And given the data we've seen, the SGLT2 inhibitors provide a tremendous mortality benefit. So if you don't like MRA, which are dirt cheap, then you put your SGLT2 inhibitor. But all the experts have called this the Fabulous 4 or the Fantastic 5. I mean, I think we really just have to use this. As I showed in that slide, if you use that combination, you're going to improve mortality, hard endpoint, and survival by 6.3 years. Plus 6.3 years is not a small thing in somebody who's 54 years old. So I think the value to the patient's life really, we have to just go beyond these theoretical financial considerations.
And Dr. Bashir, how would you use the once-weekly GLP receptor agonist?
It's
daily, but how about the once weekly?
The once weekly, we have 2 formulations. We have the dulaglutide that comes in 2 formulations. Dulaglutide once weekly comes in 0.75 and 1.5 milligram. Actually, they don't recommend the titration. The 0.75 is being used mainly in Japan, but what we use it here is 1.5 milligram once weekly. The patient might have the symptoms over the first week, but it tends to resolve after 2 to 3 weeks. The semaglutide is also once weekly, but is available in multiple doses. So we start with 0.25 once weekly for 1 month. Then we increase the dose to 0.5 milligram weekly for another month. And then we go for the highest dose available until now, which is 1 milligram weekly, and the patient will continue.
Okay, excellent. Well, thank you very much for all our speakers this evening. It's been an excellent presentation, excellent case discussion. We are 5 minutes away from finishing. If you want to get the CME, please fill out your CME form, and this will be available after 14 days. The webinar is also on demand on the Emirates Diabetic Society website. And also remember that next week we have our last and fourth part of the Cardiometabolic Academy, which is next week. Also, please stay tuned for the Diabetes and Endocrine and Thyroid Connect, and also the Young Leaders Forum on the 14th of July. With that, I'd like to thank all of our speakers, the Emirates Cardiac Society, the Emirates Diabetic Society, and Novo for covering this Cardiometabolic Academy. And I hope to see you all next week. Thank you very much and good night.
Thank you very much. Goodbye.